Okay. When the program committee got together 6 months or so ago and we started talking, or even before that, we started talking about, part of the program, one of the parts of the program that I really look forward to the most is right now, which is the debates. And so we have some great speakers. I think we have some relevant topics to discuss. And the first one we're going to discuss is about USMLE pass-fail. You know, February 12th, 2020, the National Board of Examiners decided that USMLE would become a pass-fail exam. There was concern that medical students were spending more time concerned about the, step one than they were actually the medical school curriculum. And so it's become pass-fail. And I've asked a couple people that are deeply involved in resident education to debate this topic. Before we introduce the first debater, though, I would ask that you all pull out your phones, go to the Attendify app, and vote right now whether you're in favor, pro, or con, that USMLE is pass-fail. And so if you go to Attendify, you go to the upper left-hand corner, you hit the bars there. It should give you a drop-down menu with polling. If you click on polling, you should be able to vote now. Oh yeah, the number, if you look on the screen here, that's the number that you have to input in order to get to the voting there.
Can't see the screen from the online view.
Yeah, the number is 73400522.
Oh, I didn't see the polling. I've been too busy.
So I know I placed my vote, but I haven't seen anything come up yet, but it should come up here in a minute. The hope here is that our debaters are going to try to sway you in their favor. Is the voting okay? Is it working okay? Okay. Yeah, I think he's going to pull it up here. We might have to try one more time.
Why don't let's see what it is.
Okay, so I see a bunch of people have voted, so we'll see in a little bit. So, can you show us the results? Okay, here we go. So the votes are in. Okay, so our first debater is Associate Dean for Morehouse College, Dr. Erica Sutton, and she'll speak against USMLE being pass-fail.
Great, thank you. I am happy to present to this sage audience of reasonable and like-minded individuals. I have no financial incentive or collaborative research to disclose relevant to this topic. In a series of slides based on fact and dispelled myths, I am going to show you why being blind to learner deficit merely allows us the comfort of pushing forward underprepared trainees and shift our biases to more implicit domains. Further, I'm going to give you insight into exactly what the USMLE, the National Board of Medical Examiners, is proposing and suggest alternatives. So, it is true that step one does not predict success as a physician, and in fact, it only has a 50% positive predictive value for higher faculty evaluations in surgical residency. But that is because the USMLE was designed as a licensing tool. In this instance, we have misused the tool and then are suggesting that instead we blunt it further by making it pass-fail. You may have also noticed in your own schools, in the learners that you teach, that students no longer attend lecture, and that they are doing so in favor of commercially available materials that help them prepare for step one. This is because the commercial resources are doing a better job of preparing them for this assessment. This is not a substitute for the continuous quality improvement that needs to take place in the preclinical curricula to teach these components. The USMLE provides feedback to the student and the educator, as any assessment would and should. And lastly, students of low socioeconomic status are disadvantaged. This is true from kindergarten through college and into medical school matriculation, unless we do something to help prepare these learners best for their careers as physicians. Failing to understand the needs of this particular disadvantaged student beyond PASS is further disadvantaging and arguably unethical. I'm going to show you what the new PASS report is going to look like. So first, in about another 4 weeks, the National Board of Medical Examiners is going to do their minimum passing score review, which they do every 3 to 4 years, and they are going to announce the new passing score. It's not clear if they're going to provide a numeric number or if they're simply going to announce how the review went. On January 26th of 2022, the new standards for pass, fail, and reports will take effect. And this is an example of the pass report that students will receive. I want to bring attention to the very small print under pass. It says, the information below is a visual representation of the content weighting on this examination. It is not feedback to the student on their performance. If your student passes, they are simply going to receive a one-page report that discusses the weighting of the content on that exam. The fail report. The fail report will be 4 pages. The first page is going to show your student their performance in reference to the low pass performance. This is an odd reference range. Pages 2 and 3 will give them feedback on the content areas and let them know if they performed below a person who was a low pass, at the same level of someone who was a low pass, or higher than the low pass standard. The final page, again, describes the content distribution on the exam. If you look here, you'll see there is an unlabeled axis for the x-axis, and this is exactly how the students will receive their report for failing. So I want to show you exactly what we have been doing with this data at Morehouse School of Medicine. This paper was published in 2018, but we collect and we review this data closely every year, and you can see that we intentionally accept a diverse learner whose average MCAT is between 495 and 501. However, through our preclinical curriculum and our tutoring and support services, we are able to improve their scores and their distributions to that of the national curve. I'm going to take a moment to talk to you about this range right here. This is passing. It's this first blue peak. This is passing, and this is 205, okay? Here between 195 and 205 are my highest risk for clerkship subject exam failures. These are the students who will then go on to clerkships and fail one or more clerkships because they fail the shelf exam. This is a very important group of students to identify and to support in this next phase of their learning. not to put a blanket across their performance as pass or fail. Let's talk about some myths, okay? Student well-being is compromised by a high-stakes exam. There is absolutely nothing wrong with presenting students with intensity for a high-stakes exam. Student well-being is compromised when they are poorly prepared for that assessment by themselves or their educators, and they are not taught the resilience that they will need to be practicing physicians. The other myth, the USMLE indicates how hard an individual is willing to work. Nothing could be further from the truth. The USMLE indicates the learning and mastery that a student has achieved and where those gaps remain. So what comes next? Well, now, as you must know, the SAT and the MCAT are increasingly waived. 80% of preclinical curricula are pass-fail in medical schools, and the USMLE Step 2 clinical skills is canceled. It's not coming back, okay? So, naturally, the USMLE Step 2 CK becomes the new high-stakes metric. There's both evidence of that in your own backyard, but also in the literature. And metrics that are subject to implicit bias will soon emerge as predominant selection criteria in our choice for residency programs. I think I've made it very clear why being blind to these deficits merely allows us, learners, and educators the comfort of pushing forward underprepared trainees and shifting our biases to more implicit domains. Thank you.
So next, arguing and coming from behind, I may say, from the initial polling, Dr. Ben Jarman is a general surgeon and general surgery residency program director at Gunderson in Wisconsin, and he will be arguing for pass-fail.
I have nothing to disclose, except for the fact that I've experienced unnecessary stress, lost precious time with my wife and children, and suffered financial consequences of the time I've had to invest, with the perhaps unlikely hope that I will garner the favor of your approval of my work. My experience actually pales in comparison to the thousands of students who have had to prepare for the step one in their quest to obtain a score that does not correlate with their potential ability as a surgeon. In 1996, Dr. Melnick and his co-authors reported data regarding the then new USMLE Step 1 and 2 results from the 1994 graduating class. The authors noted remarkable racial and ethnic disparities as noted. The mean score for whites was 203 compared to 180 for African Americans and 190 for Hispanics. Similarly, the initial pass rate was 93% for whites, but 58% for African Americans, and 77% for Hispanics. Ultimately, things got better with 99%, 94%, 99%, 88%, and 94% ultimately passing the exams. Notably, there were also less remarkable differences in gender favoring males for the first attempt. Inexplicably, we have continued with this dreadful experiment for the ensuing 27 years. Dr. Arjanecki, Dr. Sutton, members of the program committee, and my colleagues in the Western Surgical, it's an honor to talk to you today in my quest to demonstrate why the USMLE Step 1 should be a binary pass, no pass exam. My address will speak to several categories of stakeholders, which I have listed here. It's well known that underrepresented minorities are more likely to score poorly on standardized exams. I wish I could say that there's been improvement in this correlation with the Step 1 since those initial data points in 1994, but I cannot. Lipson and co-authors noted statistically significant differences in Step 1 exams between underrepresented minorities and whites in their residency classes. But amazingly, there was absolutely no difference in observed structured clinical exams at the start of the residency over that same 5 years of assessments. Likewise, this report by Rubright and co-authors in 2019 again demonstrated persistent variations in scores. And this study, by Williams and co-authors, demonstrating similar findings for the 2015 and 2016 classes. Despite this acknowledgement by surgery education leaders, we have not been able to substantially improve the situation. Instead, program directors have become increasingly reliant on Step 1 as an initial screening measure to simply qualify to review an application. This has limited diversity in surgery training for far too long, and it's limited access of many to surgical training. The percentage of underrepresented minorities in medical schools continues to lag behind our general population, and having further overt barriers such as Step 1 is simply demoralizing. On the medical student front, many articles have been published noting support for the change to a pass-fail Step 1. Perhaps surprisingly, the concerns raised for the medical student are not typically on the level of equity. Regardless of gender or race, the Step 1 has simply taken over any sense of personal wellness or resiliency that can be achieved during the first 2 years of medical school. We know that medical students have significantly higher rates of burnout and depression compared to age matched samples of college graduates. And we know that Step 1 is reported to be a major source of that stress. Medical schools push students to take time away from experiences simply for the exam preparation. Expenses are a major issue. Students pay for review courses, online materials, practice exams from the NBME, bowing to the pressure to dedicate all possible resources towards achieving a score on an exam, which primarily focuses on basic science, and there's a paucity of clinically relevant material. Students typically spend more than $2,000 on the process, more if they fail the exam. $2,000 for a medical student who's already paying tuition to a medical school to not provide the education they need over a couple of months of preparation. Instead of taking advantage of a critical time in their development as physicians to practice technical skills, develop their emotional intelligence, and participate in patient care, students spend 1 to 2 months memorizing these databanks of questions, staring at computer screens in hopes of regurgitating information on an exam correctly. The change to a pass-no-pass exam would de-emphasize the performance on the exam, and students would be able to shift all of that wasted energy and time and money in test preparation to more tangible areas of their maturation as physicians in their chosen field. How about on the medical school front? Medical schools provide rich data about each medical student with descriptive dean's letters, formidable curricular design, assessments of professionalism and communication skills, transcripts, NBME shelf exams, and rotation assessments that are more than adequate to determine if a residency candidate is able to be successful in residency. Undergraduate medical education representatives have steadfastly supported the transition to a pass-no-pass system. With this change, and despite the fact that medical students are paying exorbitant fees to medical schools to usher them to the success of a match, schools must re-engage with some level of comparative assessment to transition student learners to GME. This must include an outline of where students will need help, where they will struggle, and what challenges are to be anticipated. I'd argue that both successful completion of residency and the first-time attempts at board certification should be formal outcome measures of each medical school with publicly reported outcomes. On the program director front, and I specifically mean surgery program directors, those directors in general surgery and surgical subspecialties, you have far too long relied on USMLE Step 1 as a predictor of success as a surgery resident and ultimately as a surgeon. Many refer to Dr. DiVirgilio's work on this matter, but notably, it was a score of less than 200 on Step 1, which equated to challenges with the American Board of Surgery qualifying and certifying exam. That score is only 1 or 2 points more than the failure on the step exam, and those students with that low of a step score are likely to have other manifestations in their transcript. It's also notable that Dr. DiVirgilio and his co-authors publicly published this commentary within which they state, by making Step 1 pass-fail, the hope is that students will focus on learning medicine instead of obscure facts, and that without a score, residencies will take a more holistic approach to recruitment. In addition, our own Western Surgical Association members, Steve Stain, John Potts, they contributed to this recent publication, again, rehashing this relationship between step scores and ultimate board passage. The authors did not review or mention ABSITE performance, which is also predicted of the ABS exams, and a tool that's readily available to program directors throughout training. Surgeons need to consider the entire residency application when assessing applicants and must not solely rely on biased objective measures. All allopathic and osteopathic students should be successful in their chosen field, provided the program directors evaluate them appropriately, do formal intake assessments, and address challenges. Even my co-debater, Dr. Sutton, agrees with me, serving as the first author on this manuscript where she clearly states that a high overall board pass rate can be achieved regardless of USMLE scores. Colleagues, the time has come to put the pandemic of the 3-digit USMLE Step 1 to rest. In short, trust the vaccine of a pass-no-pass system, trust the bureaucracy, drink the Kool-Aid. It's the right thing to do for our medical students, all advocates for surgery education and diversity, and our society at large. I've outlined several clear benefits to the upcoming change, which I will not reiterate. Thank you.
So each candidate, I guess, will have a 3-minute opportunity to give their rebuttal, and then we'll have discussion from the audience after both rebuttals. So Dr. Sutton, you're first.
Thank you. Can I have my slides back up, please? First, I always reference myself, so I certainly in the first slide. I want to talk about student anxiety, okay? In 2013, we felt that these students were stressed out because we were giving them grades in the preclinical curriculum. And so what did we do? We did high quality research. I also pulled this paper from Reed and Darby that said the only thing that mattered whether the students were experiencing high levels of anxiety or whether or not they were in a pass-fail curriculum. So fast forward 8 years to today, and again, students are maximally anxious about this high-stakes exam, even though they have been given a pass-fail curriculum. I say this to say that blinding ourselves to these scores is merely kicking the can down the road. And they're going to fail their shelf exams, and then they will not be able to match into surgery or any other specialty that we should choose. So I agree that program directors in surgery and all disciplines need a holistic approach. But the very things that you have suggested as a holistic approach are perfect examples of changing how we as educators function, and not merely the exam or assessment result that we use to help improve ourselves and our students. Thank you.
I don't have any additional slides. So I'll use my rebuttal just to reply to a couple of the inaccuracies and falsehoods in Dr. Sutton's well-prepared address. First of all, pushing forward trainees. This is exactly what we need to do. Our medical schools shouldn't be the ones to correct medical students. They really should be the ones to pass them along in order to maintain outstanding U.S. News and World Report findings. They need to be the ones to respond to a tuition that they're receiving. And you're paying for an education. These students don't want to get failure. They really need to be uplifted throughout their training. Dr. Sutton and I both are somewhat old school. She's just 2 years older school than I am, but we both trained before the duty hours were implemented. And I suspect the majority of our residency was without duty hours. But I've developed a softer heart for these kids growing up in this age. And I recognize that what they want is a more generous system where they can get what they want. In addition to that, there was a comment made about the at-risk students, 195 to 205. I totally agree. I think the USMLE fail rate should be higher, and I think that we could get that accomplished. Last, even if one is swayed by her well-outlined position, USMLE Step 1 results have ultimately become this vehicle for worsening mental health, have contributed heavily to longstanding racial and ethnic disparity, and have taken the spotlight from overall qualified candidates to ones and reduced their soul to that of a single 3-digit score. Thank you.
Okay, we have about 5 minutes to open it up to the audience. Any questions for any of the debaters here?
All right, Collins, Los Angeles. Full disclosure, I was a 13-year program director of general surgery, and I've been DIO at my institution with 45 programs for 3 years. I get both sides, yet how does a pass-fail on USMLE Step 1 differ from the paradigm of Samuel Shem in the House of God, where it said, if you'd like to attend a residency at Man's Best Hospital, fill out and return this card.
Is that a question? Are we still arguing the same side? I think we are, right? Okay, go ahead.
Stephen Stain, Burlington, Massachusetts. So I want to agree with Dr. Sutton. I think the pass-fail has the possibility of preventing underrepresented minority or less advantaged students from standing out in the crowd. I think what's likely to happen is if you come from an Ivy League school or a top 20 school, you'll get interviews. But if you come from that school and you post a 240 or a 250, you'll get interviewed. If it's just a pass-fail, it's unlikely. And I guess, Dr. Jargon, how will you identify those URIM students that you say you want to match to come get interviewed at your program if you don't have a Step 1 score to identify them for?
So I think the question was, how do I select those people? And quite honestly, I have huge challenges to this because my institution screens all applications for gender, race, birthplace, picture, etc. So it's very hard for me to actually select applicants with diversity in mind, and that's a challenge I don't know really how to overcome.
Dr. Dalamati?
Dr. Sutton, I have a question for you. And this was true 40 years ago, and it's still true today. And one of your first slides was that most of the preparation done for the USM LME is done by commercial prep. So how can you support a system that's gamed? If you're a wealthy guy or a wealthy woman and you can afford to take some course, 40 years ago it was the Kaplan course, now it's probably something else. And I can remember 40 years ago not being able to afford that course and not having, it's like having the game plan before you go into the game. And to me, until you fix that corruption or that aberration in the system, it's a worthless score to me, because if you take the prep course, you're going to do well, and if you can't afford to take the prep course, and I think Dr. Stain's point's a good one, if you're an underserved or underrepresented minority and you have a great score, that's great, but it's still a gamed system if you're doing most of your preparation with some commercial outside vendor. How do you answer that?
Yeah, so short answer, our diversity categories at a historically black college and university are not only underrepresented in medicine, but also low socioeconomic status separately. And that is a disadvantage for them. And that means, and I have students who can't afford an additional $60 a week to park in downtown Atlanta. So it means that I have to be better at teaching. I have to do the continuous quality improvement work on my preclinical curriculum that is going to prepare those students. It's the same that it's the same thing that we're looking at with residency performance and competency. You know, we're starting to apply more metrics and validated assessment tools about their independence and their autonomy. We cannot get lazy at the preclinical phase of education.
This has been a great debate. So how much of this do you think is risk management? I've seen medical schools that are aiming to get excellent graduates, and so they go, they got grades, and so their scores are high. Then they have one or two students that kill themselves, and they go to a pass-fail, and then their scores go down. Then, you know, they forget about the deaths from 5 years prior. They go back to a pass-fail, and they're just swinging back and forth. So how much of what these decisions are based on not being liable for the real truth, which is we have a lot of stress in our society, a lot of stress in medicine. Do we need a Simone Biles type person to bring that up like to our face and address that? And what do you think the future of that would be?
I think there's risk management all around. I mean, there's risk management on the part of the schools, on the part of the NBME, and let's not be mistaken, there's still bias in that exam. And the work to correct that exam and to eliminate that bias is costly and time-consuming. And so here's a little distracting carrot. We're going to make it pass-fail so that we don't do that work.
You know, I wish those challenges would have been taken on back in 1994, right? I mean, it's just crazy when you look at the history of this. It's really, really crazy.
Dr. Prince?
So I enjoyed the debate very much. Now, I'm an old toad and can't hear very well, but what I did hear was that the goal of pass-fail is to lessen student anxiety. And I wasn't, like Dr. Talamonte said, able to, well, I could afford, but I was too cheap to get a Kaplan course. So I focused on getting my education in medical school. And I can guarantee you my anxiety has increased through residency, faculty, on in my practice. So it's impossible as a surgeon to get rid of anxiety. So I would speak against pass and fail. And we're surgeons, we're competitive, we like to go get them. And, you know, Super Bowl winners, that's what we want to be.
Here, here.
Well, two more questions or comments, and then we'll end there. Go ahead.
Hi, Tom Sutton, no relation. I just wanted to say that I wanted to echo those comments just because I took the step 1 7 years ago now, and I felt that there's a certain level of anxiety that's inherent to our profession, and I think that a certain level of anxiety enhances learning when you have a certain amount of emphasis on a test. Obviously, there are extremes that are counterproductive, but I know that from my standpoint, I gained a lot from my studying experience from knowing that there was a high-stakes exam, because that allowed me to place a certain amount of mental emphasis on the work that I was doing. And if it was a pass-fail exam that had a 95% or 90% pass rate, that would have de-emphasized the importance of that exam in my mind, and I would not have retained the amount of knowledge that I did. So I just wanted to make that comment.
There's nothing wrong with standards.
I'm a little worried, Ben.
Hi, it's Clarissa Hoffman. Speaking as someone who took step 1 earlier this year, so I'm with the three-number score, which makes me slightly biased because now people are taking a pass-fail. I noticed that the anxiety is now no longer about getting a score on step. It's more about what am I gonna do, because my score is just pass-fail. So now students are stressed out about all the other extracurriculars they gotta do to buffer their application. And on top of that, now the other question is, you mentioned how residencies or residency directors, they kind of look at the application, the whole holistic process. But if you're getting thousands of applicants, do you have the manpower to actually look at every single applicant? And if you did, then, well, step 1 score shouldn't really matter that much anyways, because you're looking at the entire holistic, application. You're looking at everything that the person's done. So if the person has a bad step 1 score, why should that matter if you're already doing kind of a holistic process? And if you aren't doing that, do you have the manpower to do that going forward?
Sure. So it's an excellent question, and I think it varies in which target group you're focusing on, be it the medical student clerkship director, the dean, or the program director in residency who has to do all this work. But it's our duty as program directors to review every aspect of the application, and we have to protect ourselves or develop our diverse, selection teams to satisfy a complete review of the entire application.
Excellent conversation. Can we pull up the voting and everybody get out their phones? We're gonna one last vote on this.
Same.
Of course, the person that wants it to not be pass-fail is competitive and excellent. Well, Ben, unfortunately, it doesn't look like you swayed too many people. No, thank you. Excellent debates. We really appreciate both of you spending the time preparing for this, and I think that was it. Let's all give them a hand. Thank you. Okay, our next debate is going to focus on transcystic common bile duct exploration versus ERCP plus slapped chole. I think if you were at the sessions earlier, we heard a little bit about this. Our first is going to be in favor of, well, yeah, I'm sorry. Let's vote first whether or not you believe that it would be better for the patient to have an ERCP plus a lap chole, maybe that day or the next day or 2 days later, versus a laparoscopic transcystic common bile duct exploration at the time of cholecystectomy. So our first speaker, it looks like, is going to be starting from behind, and that is Dr. Jonathan Myers, who is professor of surgery at Rush Medical Center in Chicago, Illinois. He's a minimally invasive surgeon, and so this is a topic that he is often debating amongst himself every day. Thank you.
All right, thanks, Mike. I have nothing relevant regarding this topic to disclose. So my objectives today are going to be first to risk stratify choledocholithiasis, then we'll go through all the treatment options, and then I'll go through the current ASGE and SAGES guidelines very briefly, and then I'll get into the meat of my talk, which is presenting ERCP, followed by lap chole. First with a literature-based review, and then I'll turn it into more of a, what I consider a reality-based review. And then I'm going to turn it over to Dr. Hoag for her discussion on laparoscopic transcystic common bile duct exploration. There's 20 million Americans that have gallbladder disease, and of those, 10 to 15% will have symptomatic disease, and of those, 5 to 20% will have choledocholithiasis. According to the ASGE guidelines, those at high risk, which is over 50% chance of having a bile duct stone, have either the presence of a common bile duct stone on ultrasound or cross-sectional imaging, and or acute cholangitis, and or serum bilirubin greater than 4, and a dilated common bile duct on ultrasound, which is greater than 6 millimeters. SAGES guidelines are similar, but they use a bilirubin cutoff of 1.7. Those at intermediate risk for having a bile duct stone, which is 10 to 50% chance, have abnormal liver biochemical tests and or age over 55, along with the dilated common bile duct on ultrasound or cross-sectional imaging, and those at low risk have no predictors present. So our treatment options for high-risk patients with choledocholithiasis are preoperative ERCP followed by elective laparoscopic cholecystectomy. This is known as our two-stage endolaparoscopic approach. Cholecystectomy with intraoperative transcystic or transductal common bile duct exploration, which is referred to as a one-stage laparoscopic approach. And then there's cholecystectomy with intraoperative ERCP or cholecystectomy with postoperative ERCP. For the purpose of our debate, we're just going to talk about the first two with the pre-op ERCP and elective chole against the chole with intraoperative transcystic common bile duct exploration. When we look at the ASGE algorithm for treatment of this, this was updated in 2019. You can see here at the bottom that for those with a high probability of a common bile duct stone, any of the 4 options are acceptable, all with equal recommendations by the ASGE. SAGES, same thing. For those with high risk of bile duct stones, they can either have common bile duct exploration with cholecystectomy or pre-op ERCP, follow this down, followed by laparoscopic cholecystectomy. So now that we know that both are pretty good options, let's talk about some advantages of lap chole with transcystic bile duct exploration. It's important to know that there are limited studies that directly compare transcystic with to the ERCP plus chole because most of the meta-analysis, or in fact all, look at transductal common bile duct exploration. So I kind of had to tease out some of this data to make it generalized. But it seems that there's equivalent rates of common bile duct clearance, approximately 83 to 93%, which also goes along with the paper presented earlier. There's a shorter hospital stay. There's lower cost, with one stage being less cost than two-stage ERCP plus lap chole. Ironically, both of those are less expensive than one-stage transductal plus lap chole, though. And there's no overall difference in morbidity or mortality. So those are the advantages. There are limitations, though. If a patient has a smaller friable cystic duct, generally less than 6 millimeters, it's a challenging procedure. Multiple stones in the common bile duct, most studies report over 5 make it challenging. If a stone is larger than the diameter of a cystic duct, it's tough to get out. Yes, you can do lithotripsy and some other techniques, but it's still tough. If there are stones in the common hepatic duct or anything proximal to where the cystic duct enters the bile duct, it's tough to get that out. And then unfavorable anatomy of the cystic duct, common bile duct junction, usually with a low or posterior insertion, makes this challenging. In addition, there's got to have availability of equipment, availability of operative time, knowledgeable staff, both your circulator, your scrub, your radiology technician, and the expertise of the surgeon. So virtually every study that promoted transcystic common bile duct exploration has the stipulation that says if you're going to do this, you can only do it where expertise and equipment are available. Let's get a little more information on surgeon experience. Common bile duct exploration in patients with cholelithiasis has decreased over time from about 40% in 1998 down to 8.5% in 2013. Laparoscopic bile duct exploration has decreased from 9% in 2011 down to 3% just 2 years later. At the same time, ERCP use in patients with cholelithiasis has increased from 77% in 98 up to 95% in 2013. Surgical residents graduate with far fewer common bile duct explorations, totaling 2.7 in 2000 down to 0.7 in 2018. Laparoscopic bile duct explorations are about 0.9 in 2000 down to 0.7 in 2018. Several studies report that there's a 200 to 250 case learning curve for transcystic common bile duct exploration, and Hodgson et al. Reported that in order to achieve an 80% duct clearance rate, you need to do 70 procedures over 10 years. So in reality, in addition to the previous limitations, there's a wide variability in OR time for lap chole with transcystic bile duct exploration. You can take out a gallbladder in whatever, 30, 45 minutes maybe at a teaching hospital, but a transcystic bile duct exploration may take you 2 hours or more. We're constantly under pressure to accurately schedule our cases for optimal utilization, and so patients need to know when to come into the hospital. If they come in and they have to wait an extra hour or two for their case, they get upset. And when the patients are dissatisfied, the surgeons and staff are stressed when they're running behind. This ultimately leads to, it affects our Press Ganey and other patient surveys, which has a direct relationship both on reputation and quality scores personally as surgeons and for the institution, and then it also affects reimbursement and bonus structure. So based on the review of the literature and real-life experience, ERCP followed by lap chole should be the preferred treatment for patients with high-risk cholelithiasis. Thank you.
Now arguing in favor of transcystic common bile duct exploration is Dr. Melissa Hoag, who's professor of surgery at North Shore University Health Care System. She's also the director of hepatobiliary surgery.
Excellent, thank you. Thanks for the opportunity to speak. I have a disclosure for teaching courses for Intuitive. So the agenda today I have is pretty simple. We're going to talk time, we're going to talk money, we're going to talk some sage surgical advice, and follow it up with lifelong learning. So what the last 2 years have showed us is that length of hospital stay matters. Hospital beds are a commodity. And I don't know how many of you have had elective surgeries being canceled, delays getting out of the PACU, delays getting patients from the ER, not being able to transfer people in because there's not enough hospital beds and or staff. So really, length of hospital stay matters. And vote with Hoag if you want your patients to leave the hospital faster. Let's talk about some simple ERCP route. Most of the patients, unlike the ones presented coming in through same-day surgery, they come in through the ER, they have labs or an ultrasound consistent with cholelithiasis. So they end up getting admitted to a hospital bed, end up getting an MRCP to look for stones, because like the ASGE guidelines that Dr. Myers pointed out, is that ERCP is no longer a diagnostic procedure, it's a therapeutic procedure. So the indications to do an ERCP right off the bat are limited. So say they do get to the ERCP, Well, let's make sure their lipase wasn't elevated, because if they have some elevation in the lipase, the ASGE guidelines say that you may want to postpone ERCP about 48 hours. So as you're racking up hospital stay beds, adding an anesthetic and getting your ERCP, eventually, you as the surgeon, who knows how many days after they come into the ER, get to do the lap chole. So is there an alternative? Same ER admission, and now you take the patient, do the lap chole, do your cholangiogram, and then you do a transcystic bile duct exploration. Just sounds faster when I say it, but what does the data show? If you look at the national inpatient sample, you save about 1 day on hospital beds. And this isn't some fancy system that's done 250. This is just a cross-section of the United States. But what about meta-analysis? Again, you save about 1.5 days. And let's distill down, and I won't go into detail because some of this data has been presented. But not only do you decrease the length of stay, but mostly equivalent morbidity, mortality, cost, although only 3 of the 11 studies had costs and equivalent retained recurrent stones. They also showed that common bile duct exploration had lower rates of technical failure. And if people are going to be talking about me behind my back, I want them to be saying I have lower rates of technical failure. So we all know that money doesn't grow on trees, if only it does. And yes, doing a transcystic bile duct exploration adds time, but no one's asking you to do this for nothing. More work, more pay, right? So vote with Hogue if you want to get paid more, or at least earn more RVU. So let's talk a little bit about RVU reimbursement. You do the lap chole, you get about 10.5 RVUs. You're not getting any money for the MRCP, all those days in the hospital, or the ERCP. But if you do a lap chole, add the cholangiogram, add the transcystic bile duct exploration, you're going to double your RVUs. Who doesn't like double RVUs? And that may be double time, but you would have done 2 lap choles for the same, but you don't have turnover.
Is this your first day? Yeah. Oh, that's great. You're going to get to do lots of stuff. I'll have you do art lines, intubations, crossword puzzles. Awesome. I haven't gotten to do that before. Oh, no problem. Monday and Tuesday are pretty simple, but the Sunday puzzle gets really hard sometimes. This is the all-important blue drape. It's the only thing that protects us. Protects us from what? The gravitational pull from the massive egos on the other side.
All right, touche. But no one's saying, I wish I had longer turnover. No one's saying, I wish I had more Moffitt. So I would say that, decreasing anesthesia is not only good for your patients, but it's good for your surgeons too. Now, I know we've all heard it. Eat when you can, drink when you can, and don't mess with the pancreas. I don't know one person out there is like, oh yeah, I love taking care of pancreatitis. And I would know as a pancreas surgeon, everyone's like, do you want it? Do you want it? Like, no. So, vote with Hogue if you do not want to manage post-ERCP. So I give you this randomized trial on rectal indomethacin for post-ERCP pancreatitis. The GI lead over at Pittsburgh thought this was the best thing since sliced bread. Now, I don't tell you this because I want to talk about indomethacin, but this is randomized prospective data, which is pretty reliable, showing a 9 to 17% of post-ERCP pancreatitis and 4.5 to 9% of severe. Because if you just look this up, you can pretty much find anything you want up until 1 to 40% of ERCP pancreatitis. But it's a pretty significant number, and not only patients undergoing that complication, but also an estimated $20 million lost to society for each year. And more importantly, I think, near and dear to everyone's heart is post-ERCP pancreatitis' crucial impact on endoscopist stress. And since I get most of my referrals from endoscopists, I got to keep them happy. So lastly, when I went to medical school, people said getting an MD is a license to learn for the rest of your life. So there are many benefits of lifelong learning, including creating opportunities for a better job. And the bottom line is, yes, people aren't graduating with this. Yes, people aren't doing it that much. And Dr. Myers eloquently pointed out those numbers for you. But that's our doing. There's ways that we can get better at this. And education does not need to end in medical school. So vote with Hogue if you want to continue to grow and improve. So this is a study about the practices of general surgeons and the top 10 most common procedures. You see here, number 1, cholecystectomy. This is very relevant. This is very important. And on this Cochrane review, that about 10 to 18% of cholecystectomies were done for common bile duct stones. Very high amount out there. And if you look at the number 2 on the list, it's colonoscopy, scope. You know, and the American board has voted with its feet about how important endoscopy is, where there's now the fundamentals of endoscopic surgery to graduate. It's like naturally leading us to transcystic common bile duct endoscopy. And yes, there have been studies showing this done with a balloon approach or fluoroscopy in a basket, but it's 2021. So using a spyglass technology in the OR is a commonplace. And here's a video you see after the cholangiogram was shot. The endoscopy travels into the bile duct, the basket is deployed, snatches that stone, pulls it out. And I know what you're thinking, oh, you're a fancy HPB surgeon, this isn't relatable to me, or oh, you're a minimally invasive surgeon, I can't do this. So I thought, who is the most inexperienced guy I know? You know, and so I reached out to Mike McCormick, who just graduated from a fellowship. 1 year in practice, and I was like, can you give me a video, and do you mind if I make fun of you? So here's a very good sport about both of it. So, you know, before you kind of think he's a, you know, some sort of wonder kid or, you know, savant and want to hire him, he did a course, 4 hours. We had this course at North Shore. 9 of us did it. Cost $0 for us or the institution. We didn't have to travel. The scope manufacturers came if there's over 2 people willing to do this. And so we did, and we learned how to do this. So Dr. Myers thankfully sent me his rebuttal, and I'm going to show it to you now.
I wish I could debate on the other side.
Oh, so thank you. And if Dr. Talamani can learn how to do a robot Whipple in his 60s, I think we could teach residents and the junior attendings in the masters how to do a transcystic common bile duct exploration. Thank you.
Dr. Myers, you have a 3-minute rebuttal. You better make it good.
It's a tough act to follow. Well, I appreciate the fact that you threw your own partner under the bus rather than me so much. So we all know that the altruistic purist attitude is that general surgeons should be able to manage common bile duct stones in a single operation. But in reality, despite what's going on in your institution, the training, the equipment, and the time just is not there. I mean, if, for example, I'm at a major academic medical center, I've got to have nurse, scrub nurse, radiology technician, all available. It can't be at 10 o'clock during their break, it can't be at noon during their lunch, and it can't be at 3 o'clock for a change of shift. So that's 9 different time frames that I cannot do this without blowing my head off. So I'm just being realistic, that's all. Many centers do have experienced endoscopists that are very proficient at ERCP. So the most common practice in the United States is a 2-stage approach. And I have no next slide, but it does say that preoperative ERCP followed by lap chole is the way to go. There you go.
And then Dr. Hoag has a 3-minute rebuttal, and then we'll open it up for questions from the audience.
All right, well, thanks for bringing up training, because I thought, who's less experienced than Dr. McCormick? And then I thought, well, residents. And if a resident can do it, we can do it. So this is a study from Northwestern looking at transbile duct exploration curriculum. And I graduated from their pre-curriculum, but what they showed is a 4-fold increase in doing it this way once you train people how to do it, especially residents. And then more interesting, if you look at the attending experience, and the white is there's no common bile duct exploration of the attendings, you could see in the later years, attendings without any experience are doing these, because really it's the residents that are doing the procedures and driving this. And if you look at the cost and the time, you know, it's really, you know, 4 hours a year. The cost was about $3,000 for training the residents how to do it. But what about the patient outcomes? Because I really think surgical education is really akin to surgical quality. And so what they showed was that the duration, length of stay for this transcystic approach was about 1.5 days less than the ERCP, which translated about $3,000 for patients. So essentially, one patient being done this way can fund a curriculum. or you could have industry come out and do it for free. And they've done that in this instance. This is also from the Northwestern group looking at how courses improve confidence and attitudes towards being able to do it after they went through the curriculum. And at 3 years, 86% maintained their confidence, but only 30% really increased lab common bile duct volume, and for the reasons Dr. Myers mentioned, instrument availability or staff knowledge of the procedure. But this really shouldn't be a barrier or impediment. It's a lesson learned. Like, how do you make your program successful? Make sure the instrument's there, make sure the staff's trained. And what are all your alternatives? This is a study I did at Pittsburgh looking at lap-assisted ERCP, and people with gastric bypasses can undergo an ERCP. So here we have 5 ports, a 15-port here, and really to do a series like this, we had 10 advanced therapeutic endoscopists. It's like unheard of, and we have about 3 within our system now. But if you look at this, 9% surgical site infection, which is more than a lap chole, because this 15-port is actually going into the stomach, and the scope is driving into this port to do that, and still you've got some pancreatitis. And, I didn't see that study about 250 learning curve for the transcystic, but we haven't noticed that at our institution. And this was our learning curve for the lap-assisted ERCP, about 26 for the program, about 3 to 5 for each surgeon. So I think, why should you vote with Hoag? Remember, laparoscopic transcystic common bile duct exploration gets your patients home faster. It doubles your RVU per patient and increases your armamentarium of surgical techniques. It decreases rates of pancreatitis, and we've shown the learning curve is safe, feasible, and has training program and allows personal surgical growth. This can be taught to residents and is cost effective, and it may be a necessity after bypass. Thank you.
All right, this topic is now open to the floor for debate.
Okay, Collins, Los Angeles. Let me try again. I won't be quite so rhetorical. Earlier, we heard an interesting study in this vein, and I brought up the fact that it seems about 80% of common bile duct stones pass by themselves. So anybody who does administration knows that a lot of problems solve themselves if you just give it enough time. At a bilirubin of 4, the prior probability of having a common bile duct stone is about 50%. So we do MRCP, and if the duct is clear, we're good to go. So we do highly, highly selective cholangiography, so we probably don't see a lot of those 2-millimeter stones that people are chasing for RVUs. So could you please address this thing that I don't understand, which is why are we solving a problem with a really complicated procedure if the problem is likely to solve itself?
Yeah, I mean, that's a great question. It's tough to answer. I think, like most people, surgeons don't have the crystal ball and would know which ones are going to pass and which ones are not going to pass, and know which ones may cause further problems like cholangitis, or pancreatitis. So, when you're kind of weighing the risk of taking care of the stone to try and prevent ascending cholangitis and pancreatitis versus leaving it and seeing if it'll pass on its own without an intervention, and do you leave that patient in the hospital? How often do you develop, get LFTs? How often do you call them? I think it's just we're more afraid of the known and would rather be proactive than reactive.
I think, so I am on your side, so I'm not quite sure how to answer that, but yeah, I agree. You just answered it for me. I do selective cholangiography. I agree with that we don't need to do a whole big, you get in the equipment, do all that. I don't know how much that costs, that piece of equipment. I think you guys, I'm sure, have all the data on that. But I think it's fine just to, use clinical judgment, LFTs, and see how they do. And we don't need to keep them in the hospital forever. If you have close follow-up with your patients and they have an issue, pain, jaundice, whatever, you get them right back in and then take care of it then.
Banky from Houston. We are progressively losing our procedures to other specialties like cardiac surgery, CABG, stent, gone, right? Now his esophageal perforation, EMR, esophagectomy, EMR, esophageal perforation, Apollo. Now it's POEM and Heller. So I see this other specialty, they work so hard to learn what we do. I mean, the first poem they did in our hospital, it took him like 4 or 5 hours, but try so hard to do what we do. And then what we are capable to doing, we say, well, it's too hard, takes time, let them do it. Why not we try hard and we try to keep what we are capable to do?
I think that there's two sides to this, and I know when Mike introduced it, he said, what's best for the patient, which kind of set me up on, in the defense. But there's got to be also what's best for the doctor too, what's best for our schedule, what's best for the hospital. There's so many components that fall into this that, we're not necessarily publishing on the unwritten rules, but a lot of pressures that we're all under to try and make our day run smoothly. So we have to take all of that into account, provided that the overall outcome for the patient is similar.
So we'll have 2 more questions or comments and then vote. Dr. George.
Yes, obviously you know who I vote for. So I think at the end of the day, it really goes down to what's best for the patient. And leaving a stone behind, you don't know what's going to happen with that. And the Swedish, they prove that if you leave a stone behind, there is a 25% chance of a negative outcome. And we do have, we live in a litigious society, so you leave a stone behind and you're really exposing yourself to risk, and you don't know what you're leaving, exposing the patient to what risk. So I'm, as you saw, I'm a strong proponent of, if I find a stone, no stone left behind. And yes, you can't make an asymptomatic patient better, but you can prevent further things from developing in the future.
Who better than to speak right now than somebody who can do both ERCP and lap-chole transcystic bile-duct exploration? Dr. St. Vincent, please.
So that was going to be, I'm Randy St. Hill from UNLV. That was going to be my disclosure, that I'm a hepatobiliary surgeon, but during residency and fellowship I learned ERCP, so I can do all the different techniques. And we typically use a selective process where if a patient has a stone noted on ultrasound, elevated LFTs, bilirubin that's elevated, those kind of things, then we'll do lap-chole with intraoperative cholangiogram. And then if you have a small stone, in terms of the expensive equipment, you can use a pediatric ureteroscope to get the stones out, which is something that everyone has at their hospital. You may not have anyone who knows how to use it or hook it up, but you could learn that. And just get the urology tech in the room. And then if it's a larger stone, then we'll use ERCP on table to remove the stone. But I think my real question is, how do you refute the decrease in hospital stay and the decreased cost to the patient that comes with it if you do the one-step procedure compared to a two-step where the patient's admitted for several days, gets an MRCP, an ERCP, and then finally a lap-chole anyway. And then the last problem is, if you do a lap-chole after ERCP, if you do cholangiogram after that, you'll still find stones that are retained, and then you're not sure what to do with those. Are they going to be symptomatic or not? So you have a whole nother issue.
Dr. Myers, do you want to answer?
So to refute the cost issue, that's certainly a tough one. I would just counter that with, how do you refute the reputation and other damage that you're getting from adding on a case that you thought was going to be a 20 or 30-minute case, and now it's a 3-hour case, and what have you done to the rest of your patients, and then your staff is gone, and then you have to put them on to the next day. So there's a lot of other costs that the hospital is going to accrue because of that inability to schedule things smoothly.
Okay, lively debate. We're going to do our final vote, so again, pull out your phones, and let's see if you were able to sway people, John. It's not looking too good.
Rob.
I would like to,
Voted yet? Twice. Chicago, come on.
That's right. Well, I'd like to thank our debaters. This was outstanding, better than I thought it was going to be, and I thought it was going to be great. So you guys did a great job. Thank you very much. We have a 15 or just over under 20-minute break until session number 5. That'll be moderated by Dr. Godellis. So please get some coffee, and we'll see you back here in 20 minutes.